All right, MRCOG candidates, welcome to this explainer. Today, we're going to master the absolutely crucial 2024 updates to the RCOG Green-top Guideline for Monochorionic Twin Pregnancies. Look, whether you're actively cramming for your exams or just trying to refine your day-to-day clinical practice, managing these complex pregnancies requires strict, unwavering adherence to evidence-based protocols. So we're going to break down this latest guidance step by step. By the end of this, you'll know exactly what to look for, exactly when to screen, and precisely how to intervene. Let's dive in.
So let's establish the clinical urgency right off the bat. Monochorionic pregnancies make up roughly 20% of all twin pregnancies in the UK. But here's the catch. They carry a dramatically higher risk than dichorionic twins. We are talking about significantly elevated rates of fetal loss. That means miscarriage, stillbirth, and neonatal death, along with a much, much higher risk of associated neurodevelopmental morbidity. Why? Well, it all comes down to that single shared placenta and its vascular anastomosis. It creates a highly precarious environment, which is exactly why your antenatal surveillance needs to be absolutely flawless.
Okay, here is our clinical pathway for today. We'll be covering diagnosis and the first trimester, routine second trimester screening, TTTS management, TAPS and sFGR, and finally, the timing and mode of birth.
Section 1. Diagnosis and the first trimester. This all kicks off in that critical diagnostic window between 11 plus 2 and 14 plus 1 weeks of gestation.
Picture that early ultrasound. You absolutely have to nail down chorionicity accurately before 14 weeks. For a monochorionic pregnancy, what are you hunting for? You're looking for a single placental mass and a thin intertwin membrane that inserts perpendicularly. That gives you that classic T sign. Now, contrast that with dichorionic twins, which typically show the thick lambda sign because of the thicker membrane insertion. It's a high contrast differential, and if there is ever any doubt in your diagnosis, do not wait. You must refer the woman to a fetal medicine specialist right away. Now pay close attention here, because this is a massive 2024 update you need to know for your exams regarding aneuploidy screening. Cell-free fetal DNA testing, what we often call NIPT, is now fully validated and highly recommended by the UK National Screening Committee. Specifically, it's recommended as a contingent screening test based on the results of the first trimester combined test for major autosomal trisomies in twin pregnancies. This is a real game changer and a vital update to integrate right into your early pregnancy counseling.
Moving on to Section 2, routine screening protocols. Let's build out the rigorous ultrasound regimen these patients need.
You need to burn this clinical scaffold into your memory. In the world of monochorionic twins, uncomplicated definitely does not mean unmonitored. The standard of care strictly dictates that you shift to intensive 2-weekly scanning intervals starting at exactly 16 weeks of gestation, and you keep that up right until birth. Also, right in the middle there, you'll insert a detailed routine anomaly scan between 18 and 20 plus 6 weeks. And remember, that scan must include extended views of the fetal heart anatomy.
So, what happens at 16 weeks? The crucial takeaway is that at every single 2-weekly visit from 16 weeks onward, you have to systematically measure 4 key parameters. No exceptions. 1, you measure the deepest vertical pocket of amniotic fluid for both sacs. 2, you verify that both fetal bladders are visible. 3, you calculate the estimated fetal weight discordance. And 4, you measure the umbilical artery pulsatility index. Skipping even one of these, you might just miss the subtle early warning signs of severe placental complications.
All right, grab your highlighters because here is another specific 2024 addition for the exam. You must actively screen for twin anemia polycythemia sequence, or TAPS, using the middle cerebral artery peak systolic velocity. This measurement literally has to be added to every single routine scan starting at the 20-week mark. Why? Because TAPS can just happen spontaneously in up to 2% of apparently uncomplicated monochorionic twins. So this baseline Doppler screening is now entirely mandatory. Section 3, TTTS management. We're getting into the big 3 pathologies now, starting with twin-to-twin transfusion syndrome, which complicates up to a whopping 20% of these pregnancies.
For the exam, you've got to be able to instantly recite the Quintero staging system. It's an absolute must. The baseline diagnostic criteria, Stage 1, requires strict amniotic fluid discordance. That means a deepest vertical pocket of less than 2 centimeters in the donor sac and greater than 8 centimeters in the recipient sac before 20 weeks, or greater than 10 centimeters if you're past 20 weeks. From there, it gets progressively worse. Stage 2, the donor bladder disappears.
Stage 3, you got critically abnormal Dopplers. Then the clinical picture just becomes dire, advancing to severe hydrops in stage 4, and tragically, the demise of one or both twins in stage 5. Now, if TTTS presents before 26 weeks, the guideline specifically updates the recommended surgical treatment to fetoscopic laser ablation using the Solomon technique. What this means is surgeons perform a serial sequential ablation followed by an equatorial laser dechorionization. Essentially, it's like using a laser to draw a line right across the equator of the placenta to disconnect the two sides completely. Doing this drastically minimizes the risk of recurrent TTTS and post-laser TAPS. Now, if it's after 26 weeks, management becomes highly individualized. Section 4. TAPS and SMAGR management. Let's explore how to spot and handle the remaining two major pathologies. Let's quickly contrast TTTS with TAPS, because building this differential diagnosis is vital, and exam questions absolutely love this distinction. TTTS is defined by massive fluid shifts, right? The classic oligo/poly sequence. TAPS, on the other hand, is driven by these minuscule anastomoses that cause a painfully slow blood transfusion. So at TAPS, you're going to see a significant hemoglobin discordance, which you pick up prenatally via a major difference in MCA-PSV Dopplers. But crucially, you see this without the massive fluid discordance that you'd expect in TTTS. Next up is selective growth restriction, or sGR. This one complicates about 20% of monochorionic twins. We need to break down the complex Delphi consensus definition here because as a candidate, you must know these exact bullet points to officially diagnose sGR. Okay, you need an estimated fetal weight of 1 twin below the 3rd centile. Or, alternatively, you need 2 out of the following 3 criteria. A weight discordance greater than 25%, the smaller fetus measuring below the 10th centile, or abnormal umbilical artery Dopplers in the smaller twin. Got it? Once you've actually made that sGR diagnosis, umbilical artery Doppler staging is what dictates the prognosis. Type 1 features positive diastolic flow and honestly has a generally good outcome. Type 2 shows persistent absent or reversed flow. But Type 3 is the most treacherous of the bunch. It features a cyclical or intermittent pattern of absent or reversed end diastolic velocity. This specific waveform is dangerous because it carries a notoriously unpredictable 10 to 20% risk of unexpected fetal demise, even if the scan looked totally stable just days prior. Finally, Section 5, Timing and Mode of Birth. Let's navigate the rigorous guidelines for timing preterm and term planned births. The ultimate goal here, the real balancing act, is preserving the latency period. But that period dramatically shortens as placental insufficiency and Doppler abnormalities get worse. Uncomplicated monochorionic twins, and those with successfully treated TTTS, should be offered planned birth from 36 completed weeks. For sGR type 1, you're going to pull that forward to between 34 and 35 plus 6 weeks. But for those dangerous sGR types 2 and 3, you absolutely must aim to deliver by 32 weeks to prevent sudden demise. So I'm going to leave you with this final clinical challenge to ponder as you master these guidelines for the MRCOG exam. Knowing that sudden transfusional events are literally always a risk in monochorionic twins, when is the precise moment the benefits of delivery outweigh the risks of prematurity in your patient? It's tough, right? Every single monochorionic pregnancy is a tightrope walk requiring immense vigilance, rigorous adherence to 2-weekly screening, and prompt referral for specialist therapy the second those parameters shift. Keep this framework firmly in your mind and you'll navigate these complex cases safely and confidently. Thank you so much for joining this explainer and good luck with your prep.